Now we are starting about the ventricular hypertrophy, and this is lesson 22. First we will discuss about the right ventricular hypertrophy and its features. Now remember, right ventricle receives blood from the right atrium through tricuspid valve, and the blood goes out of the right ventricle through the pulmonary trunk, and at that junction there is a tricuspid pulmonary valve. Now the tricuspid having three cusps. Now if the flow in the blood is obstructed, outflow is obstructed, then the ventricle has to pump against resistance to put the blood out of the ventricle, and this results, if it remains for some time, then it results in right ventricular hypertrophy or left ventricular hypertrophy when the outlet is damaged or is stenosed, is narrowed, or if the outlet is incompetent, more blood is coming back, flowing in from outward tract to inside the ventricle. So this is the cause for the ventricular hypertrophy. Now, right ventricular hypertrophy is less common than the left ventricular hypertrophy. It is due to the fact that left ventricle electrically is very active and far more bigger than the right ventricular activity. Thus, to result in right ventricular hypertrophy, if right ventricular hypertrophy is to show, then it has to be much more greater electrical activity than the left. So it is left which predominates. So right has to predominate electrically to produce right ventricular hypertrophy. Now, features of the right ventricular hypertrophy is hallmark. If I tell you hallmark of right ventricular hypertrophy is that in normal case, you see in V1 there is a small r, but in case of right ventricular activity, in V1 the r is taller than S. R is taller. So this is the hallmark. If you see a tall r in V1, then you are dealing with right ventricular hypertrophy, and maybe you have to have a differential diagnosis of other high amplitude R wave in V1, which we will discuss later. So, right ventricular hypertrophy will show right axis deviation. That means the angle should be 0 to plus 110. Sometime it is written in the book that normal right axis is from 0 to 90. But if it is over 110, then it is certainly plus over 110, then it is certainly the right ventricular hypertrophy. Then the second thing that you will see that the QRS complex in V1, lead 1, R wave is less positive than S wave. If you see in lead 1, you will find R is less tall, less positive than the S wave. Then, therefore, QRS complex lead 1 is more negative. Lead 1 QRS is more negative than positive. Now coming to the third point that you should remember, in lead V1 is having large having a large R wave than S1, and as the V1 electrode is over the right ventricle, so right ventricle, if it is hypertrophy, you will see a bigger R wave. The S wave in the lead one is small, whereas in V6 it is large. Note also that there are conditions other than right ventricular hypertrophy. You will find other conditions where you will find a tall R wave, like you will see in posterior myocardial infarction, some WPW syndrome, then dextrocardia. Then you will see it is associated in true posterior infarction. It is associated in true posterior infarction. So these are the causes of tall R. So how will you differentiate? You will see right axis deviation, and in V1 you will see tall R. Then it is perhaps you are dealing with right ventricular hypertrophy. It has to be confirmed through echocardiography. Now, we will also notice ST segment depression in the latter leads, V1, V5, V6, and T wave inversion. The hallmark again to see that in V1 the R is positive, there is right axis deviation, and there is S wave, deep S wave in V5 and V6. The condition in which you will see is pulmonary diseases like pulmonary hypertension and pulmonary stenosis. You will also see in some congenital heart diseases. Thank you.